All right, let's talk about pain and pain management in children. Obviously, we know we never want any kid to be in pain, so we take pain very seriously in the pediatric world. I think that's one of my most favorite things about pediatric nursing and pediatric just medicine in general is that we're very proactive and we believe kids when they say that they're in pain and we treat their pain. We treat it a variety of different ways. We don't always try and give medication to treat it, but that's a beautiful thing about kids too, is that you can distract them. You can do various different things like play and repositioning and things like that that really actually make a huge difference for them. It's not always medication that we have to give. Um, Now, three types of measurements to assess pain. So behavioral, physiologic, and self-report. Um, all three are equally important. Not everyone can do a self-report, obviously. Infants can't do a self-report. So we have to rely on different types of pain scales to get an appropriate um, guess on their pain level. And we do that by using these different various scales. And many of you are probably familiar with the FACES scale. We use that with children that are able to look at a picture and basically annotate that picture with their level of pain. So, in other words, a very, very sad face, a crying smiley face, or not a smiley face, but a crying face would indicate very bad pain, 8, 9, 10 level pain. A happy face would indicate no pain. So they have to be able to annotate that um, to what they're feeling. These are obviously developmentally appropriate. Your book outlines these very well. The visual analog scale is obviously another one that you guys are familiar with. The numeric scale, pain on a scale of 1 to 10 type thing. So, depending on the age of the child, indicates or determines sort of how this child will respond to pain. There are sort of general ways in which children respond given their age, and and this isn't across the board, but these are general things. An infant loud crying. Obviously, they're going to cry very, very loud. Um, an example of this is in clinical practice, we pierce ears at my office, and most kids' parents have them come in early, and we put like numbing cream, Emla cream, on their ear lobes, and typically we put the Emla cream on and we pierce them, and the kids cry for maybe 3 to 5 seconds and they're happy. And the moms have always asked, oh, well, do they still feel it? And we've really felt like, no, it's more so the loud gun sound in their ear that scares them. Well, I had this sort of confirmation because I pierced a child's ear that was about 5 months, and the mom didn't want to put Emla cream on it. She just said, go ahead and pierce them. So I did, and that baby cried and cried and cried and cried at a level that obviously it hurt. And that really sort of solidified for me. It was a very good example of different levels of pain, that loud crying. So interpreting those cries is important as a pediatric nurse. Facial grimaces and things like that is also body language, rigidity, thrashing. Those can be indications of pain. It's an example of that sort of loud crying. Um, Older infants, they may withdraw, so they may back away. They may try and get away from you. That physical resistance, they're going to push you away. They don't want you to touch them. They're hurting. They don't want you to come near them. That older kid's going to tell you, ouch, it hurts. Stop crying. Or they're going to be screaming, stop, stop. Um, they may push you away too. They're gonna slap at you if you're coming with them, kick at you, pushing you away. All of these things are very typical. That school age child is going to stall. My favorite example of this is in the clinical setting when we have a child that we have to swab their throat for strep and they've had it done before and they know. No, 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 no. Wait, 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 wait. Okay, I'll be one more minute. Almost done, almost ready. And they stall, 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 stall because they know what's happening. They get very, very stiff, that rigid behavior. Um, and they may push you away too, and they may scream as well. That adolescent are going to verbalize much more appropriately. They can articulate their feelings. They might get tense, but they have better body control, obviously. Typically, your typically developing adolescents not going to hit you and thrash around, but that's not going to be across the board. Um, so we have to be aware of that as well. Pain in neonates can be hard to determine. So we have neonatal assessment tools as well that are particular for the neonate. In other words, that baby who is either just born within that first sort of month of life, or those premature babies, the premature infant pain scale profile, for those babies that are born before their due date. Um, we also have pain scales that are for cognitively impaired children that aren't able to communicate appropriately. And we can also use a lower developmental level scale. So the FACES scale may be appropriate for a 12-year-old who has severe cerebral palsy, is nonverbal, and can't communicate their pain to the nurse. And then obviously chronic pain is very, very different than acute pain. And we treat chronic pain different. We take pain seriously in children. And those children, for instance, like a child with sickle cell, they live in chronic pain. So they may be at a baseline of 6 every day of their life. So when they're at a 7 or an 8, they may be able to function relatively well, but they're still in a lot of pain. And so we take that seriously and we treat that pain and we believe them when they say that they're in pain. Um, Obviously, non-pharmacologic management, like I said, play, distraction, um, re readjustment, moving, getting up, moving to the chair, doing things like that. Complementary pain medicine we can do. A heating pad for sickle cell pain in their legs or in their back. And then obviously pharmacologic management when needed, we would do that as well. Painful invasive procedures where obviously we are distracting. You're gonna meet the child life specialists in the hospital. These people are angels. They do such a great job of decreasing that stress response for these kids in the hospital setting when they're getting IV sticks, when they're getting medication given, when they're having an NG tube placed, when they're having a Foley placed. They're really, really involved with these types of situations. Even dressing changes can be traumatic for them. One thing I did mention in orientation this past week is in the pediatric setting, when a child has an IV placed, that IV is not necessarily changed every 3 days like it would be in the adult setting. That IV may be placed until it goes bad or till the dressing is so bad it has to come out. And this is just to minimize that trauma and those invasive procedures for the kiddos. All right, that's chapter 7.